Hello, dear colleagues. I'm Manjul. We have a patient number 3, 51 years old. Ayıl mı? Erkek mi? Female. She did a MR. Когда выявили? Опухоль. Опухоль қашан анықтаған? 4 months ago, on MR, the meningioma on occipital lobe, parietal occipital zone on the left side was found. And you can see on super selective non-membranes. Usually it has collaterals, and because of this spasm, it's look like the only occipital artery is giving the branches, but usually there is a good collaterals, and as we will see and we will check. And there is a mass effect and some pile collaterals also. It's look like meningioma. Окей, нужно будет ставить наружную сонную артерию. Возьмем траксес и хедвейду и пройдем. Хедвейду. Хедвейду 167 марса микрон. Okay, let's see. Usually very good connection between both meningeal arteries and occipital extracranial circulation. And let's see how it will be. Let's see. Так, сколько шприцер наш остался? Yes, and some update about the patient with the basilar occlusion. Patient is stable, and this artery and monoparesis is resolved now in the department, and now patient in the department and everything is okay. Она fielding дымсос нас остался. Yes, and I see the Vladimir Kaloshik from Croatia, from Zagreb, is online, and he's looking for the cases, and he's asking questions. For me, it's very important, and other colleagues also, but no, also. Ничего. Дамсо, Женевер, дамсо. Окей. Қазір қайда тұрсың? Нарушка кірдің ғой да, осы жерде ғой? Окей. Guiding is 7 French Fubuki. Access will be headway to 167 with the Traxxas. I like this combination. And I call the meningeal artery is a killer of a hybrid wire. That's why for the last 3 or 5 years we doing mostly with the Traxxas in combination with the Headway Duo. Yes, the Sonic is also okay, but in a tortuous anatomy, usually this combination is very useful. And it's very easy to navigate, handle. It could be combined with any liquid embolic and coils if needed. And some colleagues are using Marathon in combination with the Traxxas or Chikai X. But for me, this combination is very useful. I have no conflict of interest, just my subjective feeling. Yes, it's a nice combination. Sometimes it's very hard to find the way, but we know the anatomy and we know usually how the branches is connecting. That's why if there is no visible branches, but anatomically most of the time it will be there. It's like thrombosed inferior petrosal sinus. We know colleagues doing recanalization and catheterization. Yes, and in this case, usually middle meningeal artery is supplying that region. That's why first we'll try this axis. Yes, middle meningeal. Okay. I will take a little bit my Fubuki. Yes, and also in this territory, combination with distal access catheter could be also helpful, but yes, it's another push for the budget. If you're living in countries where you don't need to see for the budget, then it's a great combination. Так, Smart-Mask. Okay. First we will go to the distal part of the parietal branch of the middle meningeal, and then we will do super selective angiography and we'll see and we'll check. Okay, let's do angiography. Несколько режим. If it's okay, okay. If it's not, then we will go for the. It's okay. It's okay. It's nice. It should be connection. Usually, it's all the time here. I will do another one. Yes, we can see the meningioma. Now I need the Traxxas to push a little bit forward, and at the end we will check the intracranial circulation from MC and PCA territory, but it looks like some connection with the pile collaterals from the PCA. Так, назад, смарт-мозг. Назад. Вот, вперед. Вперед. Стоп. Ага. It looks like it's in a wedge position, but yeah, it's going up. I think now it's in a wedge position. Okay. Yes, usually there is a collateral from the posterior meningeal, might be, but usually we can see the collaterals from the right side also. Right and left. Yes. You can see all these meningeal branches. All these meningeal branches are supplying. Yes, from this side. It's possible to go from any of them. Dexamethasone 12 и lidocaine наберем. Yes, patient under general anesthesia because she was very scared about the pain, and she asked to give lidocaine, to give a general anesthesia. And now we will combine with the lidocaine. It's an Adnan technique. I learned how to use lidocaine from my colleague and friend Adnan Siddiqui from Buffalo. Usually we are giving lidocaine when the patient under squid donuts, under local anesthesia. But today, usually when you start to inject the MSO, it's very painful and patients start to move. But I decided to combine general anesthesia with the lidocaine intraarterial. It's a 2% lidocaine. I will give 3 cc. Yes, that's enough, I think. This is the MSO from Squid. It's a blue syringe. And then I will take Squid 12. Так. And наркоз чуть поглубже сделайте. Так, глю. Okay. I increase the radiation to see better my squid, and also you can see the meningeal artery from other side. Yes, it's very important to feel all these collaterals. It's very important. This branch we have seen from occipital supply, and you can see there is a branches coming from the right side, and there is no reflux because of this wedge position. Tag bir cubic squid, a little bit more squid. I will stop because of this supply from the occipital artery. So this network coming from the right side, from the extracranial circulation, we just cut it. And this branch is also from somewhere. I think it's it could be supplied from occipital or superficial temporal artery. Castrator. With the particles, it's nearly impossible to do. Yes, and on Friday, today is Sunday. On Friday, it was a neurosurgical conference in Almaty, and some of our colleagues. He's well-known neurosurgeon, and he said why we are doing embolization for meningioma. We need to do craniotomy and resect all these meningiomas. I was in Astana. I had the question: how many times they are doing hemotransfusion? And in our department, we made nearly 200 cases and nearly zero hemotransfusion. And if I'm correct, from our colleagues, they are doing tons, liters of blood transfusion for the patient with the brain tumors, and mostly in hypervascularized meningioma cases. I think this technology is a game changer, and no need for the blood transfusion, and we are avoiding thousands of hemotransmitted pathologies like HIV, hepatitis, syphilis. Yes, I don't understand why people still want to work like in old times. And if you see this embolization like in brain AVM embolization, yes, we now cut all collaterals and now trying to go deeply inside the meningioma. Usually it takes some time. Okay, let's see. From the beginning, I'm a neurosurgeon, and yes, it's okay for neurosurgeon to do craniectomy, but not in all cases. Тұр. Инесін шығармайық қой. Yes, and they start to touch my friends, my colleagues in presidential hospital in Astana, in Almaty, and start to say you're doing incorrect job, and I don't know how they will comment the cases of chronic subdural hematoma. The same strategy, and no craniectomy, no hematoma touching, and hematoma is resolving in next weeks. And no neurosurgery. Yeah. Okay. Yes, and the statistics is quite promising. From the meningioma cases, we resected only half of them, and half of them on observation, and only few of them is regrowing because of the genesis of meningioma, and the histology of the meningioma was atypical. It was malignant meningioma. And I think after open surgery, the rate of regrowth of the meningioma, сколько процентов? После полной резекции менингиома. Рецидив. Қанша процент? Nearly 10% of regrowth after total removal, and these guys are trying to say embolization is ineffective. I completely disagree. Nearly 25% of all these meningiomas are resolved without any treatment. Okay, I think it's going to the. Looks like it's going. Yes. We need to wait a little bit. It's like a gamma knife. It just occlude the feeding vessel, and meningioma is disappearing. And in 25% of cases, it remains stable. And most of the meningioma, if it's stable in 5-10 years, then why we need to do craniectomy? Like my colleague from Canada, I forgot the name. He all the time says we need a randomized control trial. Yes, in 2 arms, maybe it will be effective. This all goes to the collateral. Okay, I will pull a little bit because we have some connection. This is a headway duo, that's why I can pull it. With this Sonic and Apollo, it's impossible. Okay. It looks like it's inside the bone. And now, wait a little bit, and then we will push inside the tumor. He's a investigator of Tobas trial from Canada. Okay, everything is going to the collaterals. everything is connecting with collaterals. Let's do from this point. Oh, looks okay. Yes, I'm coughing for several days because of cold weather in Astana, minus 20, 25. And I'm missing Almaty. Yes. Everything is going there. Okay. Everything is inside the bone structures. It looks like it's an emissary vein or artery, but it's still inside the bone. Okay, let's wait a bit. 1 minute waiting. And interesting point, when you do expert CT, you can see all this squid inside the meningioma, but now it's nearly invisible. But usually all of the squid inside the meningioma. This is a case number 4 for today. Then we have previously totally occluded dural fistula. For control angiography, she will be last. The next patient will be dural fistula. I treated the first and last time for the patient in Taras city during the workshop, and he was already treated 7 or 8 times in the different hospitals in Astana, National Neurosurgical Center, and in Chimkent, with multiple dural fistulas and venous hypertension, and in between of them there is a patient with the corpus callosum brain AVM. Yes, we'll see. Okay. It's going same direction. Okay. It looks like it start to connect with this. Oh no, on AP it's still inside the bone. Okay, let's wait for another minute. Oh, it's very interesting. In super selective angiography it was look like this, but after starting injection we can see only the collaterals. I think this branch is also coming to the meningioma. Maybe we will take the second micro and we'll go to this bench. Надо сонда баратын сияқты. Астыңыз. We'll see. We have time. No rush. Yes. Everything is going there. Huh? It's inside the bone, man. Bone collaterals. We can see this branch. Так, не аж пересоснешь. Назад. Sonic Turspik'in bir de biz 35. Пока дайындайсыз, ашпай тұра тұрсын. 35 или 25 қайсы бар? Bir жарым 25 болса да болады, пока ашпай тұра тұрыңыздар. Бір жарым. Бірде екі әлі керек болады. Так. Gerçekmiş yine. Так, такое было, да? Назад один раз. Кто там просматривает? Я ос. Микро. Ага. Все хорошо. Ага. Так. Скриптоник дурспа или не дурспа? Оникс дурспа. Дерево вергит вот, да? Обхагит норма. Хорошо, поменьше слайд, что-то не туда идет. It's okay. Шприц напасу. Так, соны бірді бес отыз бес берсінші. 25, бірді бес 25. Ау. Пока еш нәрсе, ана көрейік, тамыр барады ма екен? Так. Я проводникмен бірге ашасыз ғой? Я аша бересіз. Because I asked for и демосо жинай салыңдаршы. I asked for Sonic 1.5 25 1.525 with the hybrid 8. We'll check the lower branch and Torque verirsen. We'll check the lower branch. We'll see. And most of the cases, the following couple of days, meningioma, if no contrast enhancement, and then if no clinical symptoms increase, we usually send the patient for observation. It's possible to observe like in gamma knife. And in gamma knives, our colleagues observing for 2-3 years, and in embolization we are observing for 6 months and 1 year. No need to go and take out all meningiomas. Так, Navigate какой сон? Не, roadmap. И последний Smart Mask колесо. Awesome. Okay. This is the same branch. Düşürdü bir екі рет кіші батырды, соны көрсетшеңдер. Супер селективно. Нет, выше. До него. Ага. Вот это. Вперед. Вперед, 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 вперед. До него. Осханди. Осханди. Ага. Ос. Ага. Вперед. Стоп. Навигейт. Угу. Уже просто. Хорошо, троишься. This is same branch, huh? This is same branch, and I think it's coming somewhere here. Same branch. Okay, let's do angiography and then change. Eskizor. Contrast. Just flip. Stop. Oh, shit. Stop. Oslo. There is a collaterals. Опа. Так, вниз мне не нужно, мне нужно вверх. I need to go up, don't down. The Sonic is 1.5 by 1.5, that's why this bezel could be too small. Okay, it's another wedge position. Also. Let's check. I'll pull it a bit. No, it's quite tonic. Okay. I hope it will connect with the other side, and that's why. That was good. Squid tunic. We'll see. If not, it's a preparation for the craniectomy and craniotomy and subdural hematoma prophylaxis. Норм? Так, дымысы? Дымысы? Я кондер 22 қойсал дейді. Кондер 22 қойсал дейді. Дала салқын ғой. Okay, let's see how much we can push it. Так, не глют қойсал. Glue. Okay, it will be first injection. Okay, let's collaterals. Some part is going to the meningioma and some is going to the collaterals. Okay. I think we can finish. Yes. Usually it's a rupture of the meninge. Написано. I think it's enough. Enough is enough. Yes, the occipital is stopped. Назад. You can see the occipital is not yet not going inside the intracranial circulation. It's okay. And now we'll check the vertebral-basilar system. So what is that? Okay. Так, келесі пациентке келе берсін. Twitchy issue. Might be pile collaterals. Okay. Контрольный КТ. Okay, let's wait for the control CT to show how it's. КТ қойып болғаннан кейін КТ-ны үлкен экранға шығара саласың. Я екеуін қоясыз, и қайттан екі сквит-12 қоясыз. Пока пишем. Пишем, и звук тоже. Сейчас посмотрим. Пациент келе берсін. Конец жоқ, конец 3 минуттан кейін. Что там Маратым говоришь?
Отырсың ба?
Ұзақ қарадың ба?
Маған басқа еді деп.
Қалай өзім де әдемі тұрады? Бай өзім де әдемі тұрады.
Бәрі нормально, бәрі. Маған қай жерден болса, сүйшетей деген не басылады дейді. Сүйшетей, васкулаттың
Не бас, не аяғы жоқ дейсің.
Что значит нет? Надо просто не алгоритм, кім-кімге беру керек, и надо раздать. Мне кажется, это значит.
Sorry.
Будем.
Okay. Patient is ready for CT. 5 seconds CT, low dose. Okay. It's not me coughing, it's a Marat coughing. Yeah, it's okay. Okay. Все, бітіре
Подключи.
Next patient. Okay, next patient. This is meningioma. You see, there is a squeak and it was not visible on angiography, but now you can see. It's inside the tumor. Yes, all this inside the tumor, and we will do control MR in next 2 days on Tuesday, and I will share the images on Neuradict and our local discussion on neurocourse. Now I want to show you the squid inside the book. It's not outside, it's everything is inside, and we didn't knee cranial nerve, and yes, also we cut the occipital supply, you see. Okay, and now we can finish. We can finish in next 30 minutes. We are waiting you on the next case on brain dural fistula. Thank you. See you in 30 minutes. So.